by Oluwabukola Aderibigbe and Bello Mudasiru. This is our outline with our introduction, classification, etiology, pathogenesis, clinical features, examination findings, investigations, staging, conclusion, and references. The normal thyroid gland is impalpable. A goiter is defined as an abnormal enlargement of the thyroid gland. It is a visible or palpable enlargement of the thyroid gland. For the gland to be palpable, it must be at least 40 grams. The usual weight of the thyroid gland is 15 to 25 grams in adults. The swelling appears in the lower part of the neck and retains the shape of the normal gland. The swelling characteristically moves upwards on swallowing because of the gland's attachment to the trachea. Patients may have a dry mouth, and when asking them to swallow, water should be provided. The enlargement results from various causes such as iodine deficiency, autoimmune diseases, infections, and neoplasms. Goiter can be classified based on its appearance, etiology, and whether it is diffuse or nodular. Almost all diseases of the thyroid gland are associated with its enlargement. A goiter may be associated with 1. A normal thyroid hormonal activity, which is known as euthyroidism. 2. Increased thyroid hormonal activity, known as hyperthyroidism. This is the commonest physiological disorder in our environment. 3. Decreased or absent thyroid hormonal activity, hypothyroidism. It has been estimated by WHO that there are at least 200 million people in the world with goiters. Now, a goiter can be classified based on different criteria. We have a simple goiter, which is usually euthyroid. And under that simple goiter, it could be diffuse hyperplastic goiter or a multinodular goiter. It could be a toxic goiter, which is diffuse Graves' disease, a multinodular goiter, a toxic adenoma. A goiter could be neoplastic, being benign or malignant. It could be inflammatory, being autoimmune, granulomatous, fibrosing, infective, or amyloid. A simple goiter is a goiter which is neither associated with increased nor decreased thyroid hormonal activity and is also not neoplastic. It is therefore a goiter with normal thyroid hormonal functions. A simple goiter occurs in all communities of the world without regard for climate or race. Under this simple goiter, we have the diffuse hyperplastic goiter. A diffuse hyperplastic goiter corresponds to the first stage of the natural history. The goiter appears in childhood in endemic areas, but in sporadic cases, it usually occurs at puberty when metabolic demands are high. If thyroid-stimulating hormone stimulation ceases, the goiter may regress, but tends to recur later at times of stress, such as during pregnancy. The goiter is soft, diffuse, and may become large enough to cause discomfort. A colloid goiter is a large stage of diffuse hyperplasia when thyroid-stimulating hormone stimulation has fallen off and when many follicles are inactive and full of colloid. A nodular goiter is also known as a multinodular goiter. It can occur in any age group from neonates with congenital goiter to the elderly. The peak incidence is between 31 and 40 years. It affects women 10 times more frequently than it affects men. Endemic goiter commonly affects adolescents, with both pubertal boys and girls being equally affected. However, it tends to disappear in boys as they grow older, while it persists in girls due to increased metabolism, leading to a higher prevalence in women later in life. Nodules are usually multiple, forming a multinodular goiter. Occasionally, only one macroscopic nodule is found, but microscopic changes will be present throughout the gland. This is one form of a clinically solitary nodule. All types of simple goiter are more common in females than in male, owing to the presence of estrogen receptors in the thyroid tissue. We have clinically discrete swellings. A discrete thyroid swelling are common and are palpable in 3 to 4% of adult population in the UK and USA. They are 3 to 4 times more frequent in women than men. They are the solitary non-toxic nodule or the recurrent non-toxic nodule. A solitary non-toxic nodule is a single non-cancerous lump that forms within the thyroid gland. These nodules are usually asymptomatic and do not cause any thyroid dysfunction. A recurrent non-toxic nodule refers to a benign thyroid nodule that reappears after being previously treated or observed. These nodules are typically non-cancerous and do not cause thyroid dysfunction. Toxic goiter, this is another classification. It is a type of goiter where one or more nodules in the thyroid gland produce excess thyroid hormones, leading to thyroid toxicosis. It can be a single nodule, as per a toxic adenoma, or multiple nodules, toxic multinodular goiter. Under this toxic goiter, we have the primary diffuse thyrotoxicosis, also known as Graves' disease. It is commonly known as Graves' disease, and it is an autoimmune disorder that leads to overactivity of the thyroid gland, hyperthyroidism. Graves' disease, a diffuse vascular goiter, appears at the same time as hyperthyroidism. It usually occurs in younger women and is frequently associated with eye signs. The syndrome is that of primary thyrotoxicosis. It predominantly affects young women, but can occur in men and older individuals as well. The disease is characterized by the presence of eye signs, such as bulging eyes, like the picture that we have below. Secondary thyrotoxicosis arises in a thyroid that has been previously affected by another disease. It is typically observed in middle-aged individuals and is generally not associated with eye signs, unlike primary thyrotoxicosis. Pre-existing conditions leading to secondary thyrotoxicosis include simple multinodular goiter, which is multiple thyroid nodules that produce excess thyroid hormones, often seen in older adults with long-standing goiter. A solitary nodule, which is a toxic nodule, which is a single overactive nodule within the thyroid. It may be a benign adenoma or a localized area of hyperplasia. This type of hyperthyroidism is usually mild. Neoplastic thyroid nodules. They can be classified as either benign or malignant. And under benign neoplastic nodules, we have the adenomas. Follicular adenoma is a benign tumor derived from the follicular cells of the thyroid, typically well circumscribed and encapsulated, and it does not invade surrounding tissues or metastase. A Hürthle cell adenoma is a variant of the follicular adenoma. It is composed of large cells with abundant granular cytoplasm, that is the Hürthle cells, generally benign but has a higher potential for malignancy than the typical follicular adenomas. Under the malignant neoplastic nodules, we have carcinomas. A papillary carcinoma is the most common type of thyroid cancer. It typically presents as a painless nodule in the thyroid. It has an excellent prognosis with high survival rates. A follicular carcinoma is the second most common type of thyroid cancer, and it tends to invade blood vessels and spread to distant organs, the lungs, and the bones. Generally, it has a good prognosis if detected early. A medullary carcinoma arises from the parafollicular C cells, which produce calcitonin. It can be part of multiple endocrine neoplasm syndromes. It requires screening for associated conditions and genetic counseling. An anaplastic carcinoma is a rare but highly aggressive form of thyroid cancer. It presents with rapidly growing neck mass, and it has a poor prognosis due to its aggressive nature and resistance to treatment. Thyroid lymphomas are rare and are usually associated with Hashimoto's thyroiditis. It presents with rapid thyroid enlargement and often systemic symptoms like fever and weight loss. Thyroiditis. Thyroiditis is the inflammation of the thyroid gland, and it can present in various forms. The first form is Hashimoto's autoimmune thyroiditis. Hashimoto's thyroiditis is an autoimmune condition where the body's immune system attacks the thyroid gland, leading to chronic inflammation and hypothyroidism. Decravane subacute thyroiditis is also known as subacute granulomatous thyroiditis. It is a self-limiting thyroid condition, often following a viral infection. Riedel's thyroiditis is a rare form of chronic thyroiditis characterized by extensive fibrosis of the thyroid gland and surrounding tissues. Under the etiology, a simple goiter may develop as a result of stimulation of the thyroid gland by thyroid-stimulating hormone, either as a result of inappropriate secretion from a microadenoma in the anterior pituitary, which is rare, or in response to a chronically low level of circulating thyroid hormones. The most important factor in endemic goiter is dietary deficiency of iodine, but defective hormone synthesis probably accounts for many sporadic goiters. Under the diffuse hyperplastic goiters, we have puberty. During puberty, hormonal changes can stimulate the thyroid gland, leading to temporary goiter formation, increased thyroid hormone demand due to growth and development. In pregnancy, there are elevated levels of human chorionic gonadotropin, and increased metabolic demands can cause goiter in pregnant women. Thyroid gland enlargement is often a response to increased hormone production requirements during pregnancy. Primary iodine deficiency, which is endemic goiter, it occurs in regions where dietary iodine intake is less than 100 micrograms per day. Iodine is essential for thyroid hormone synthesis, and deficiency leads to compensatory thyroid gland enlargement. Secondary iodine deficiency. Goitrogens of the Brassica family. It commonly includes vegetables like cabbages and soybeans, which contain substances that interfere with thyroid hormone synthesis. It is more prevalent in parts where these vegetables are a staple diet. Excess dietary fluoride. High levels of fluoride can affect iodine metabolism and thyroid function, leading to goiter. Drugs such as para-aminosalicylic acid, lithium, phenylbutazone, thiocyanate, potassium perchlorate, antithyroid drugs, radioactive iodine can also cause goiter. This hormonogenetic goiter is a genetic defect in the thyroid hormone synthesis, which can lead to compensatory thyroid enlargement. In multinodular goiter, it can be caused by fluctuations in thyroid-stimulating hormone levels, iodine deficiency, goitrogens, just like the cabbage, soybeans, hereditary factors, dyshomogenesis. In clinically discrete swellings, incomplete treatment due to inadequate removal of the nodule can lead to recurrence. Natural growth cycles, iodine deficiency, genetic factors. Some individuals may have genetic predisposition to developing thyroid nodules. For the pathogenesis, a simple goiter has the pathogenesis in the following stages. The first stage is persistent growth stimulation causes diffuse hyperplasia. All lobules are composed of active follicles and iodine uptake is uniform. This is a diffuse hyperplastic goiter which may persist for a long time but is reversible if stimulation ceases. Later, as a result of fluctuating stimulation, a mixed pattern develops with areas of active lobules and areas of inactive lobules. Active lobules become more vascular and hyperplastic until hemorrhage occurs, causing central necrosis and leaving only a surrounding ring of active follicles. Necrotic lobules coalesce to form nodules filled with either iodine-free colloid or a mass of new but inactive follicles. Continual repetition of this process results in a nodular goiter. Most nodules are inactive and active follicles are present only in the internodular tissue. For primary diffuse thyrotoxicosis or Graves' disease, the body's immune system mistakenly attacks the thyroid gland, producing antibodies known as thyroid-stimulating immunoglobulins. These antibodies mimic the action of thyroid-stimulating hormone, causing the thyroid gland to produce excessive amounts of thyroid hormone, thyroxine T4 and thyroidothyronine. For thyroiditis, the immune system produces antibodies against thyroid peroxidase and thyroglobulin, leading to the destruction of thyroid tissues. In Decroven's subacute thyroiditis, viral infections lead to granulomatous inflammation of the thyroid, causing the release of thyroid hormones. Riddle's thyroiditis. For Riddle's thyroiditis, the exact cause is unknown, but involves the replacement of thyroid tissues with dense fibrous tissues, often extending to adjacent structures. Now, the clinical features. For diffuse hyperplastic goiter, most individuals with this condition are asymptomatic, and the goiter is often discovered incidentally during a physical examination or imaging studies. A node swelling at the base of the neck is the most common presentation. Larger goiters can cause symptoms due to compression of nearby structures such as dysphagia, difficulty in swallowing, hoarseness due to compression of the recurrent laryngeal nerve, dyspnea, that's difficulty in breathing, especially when lying down, cough resulting from pressure on the trachea, globus pharyngeus, which is a sensation of a lump in the throat, and pain, but pain rarely occurs except if there's hemorrhage or rapid growth of the goiter. For a nodular goiter, they usually present with symptomless swellings. The majority of patients with non-toxic nodular goiter present with a symptomless swelling in the neck. Many seek removal of the goiter for cosmetic and social reasons. The swelling typically grows over many years. Pressure symptoms would cause the patient to experience hoarseness of the voice, difficulty in swallowing, difficulty in breathing, postural snoring during sleep. For primary diffuse thyrotoxicosis or Graves' disease, there's a diffuse thyroid swelling, which is a hallmark of Graves' disease, where the thyroid gland becomes diffusely enlarged. The hyperthyroid symptoms include weight loss, increased appetite, heat intolerance, palpitations, and nervousness. Eye signs such as exophthalmos, lead lag, and periorbital edema. These eye signs can occur concurrently with the thyroid swelling. In Hashimoto's autoimmune thyroiditis, the symptoms include fatigue, weight gain, cold intolerance, constipation, dry skin, hair loss, high levels of thyroid antibodies, and the thyroid enlargement. In Derquain's subacute thyroiditis, it is characterized by acutely painful enlargement of the thyroid gland. Symptoms include dysphagia, pain radiating to one or both ears, sore throat, and general malaise. Often, the sore throat and ear pain overshadow the painful goiter, leading patients to present at the ENT clinics. The thyroid gland is usually slightly enlarged and very tender, often affecting a single nodule. Fever, malaise, and hyperthyroid symptoms, which include palpitations and weight loss. Transient hyperthyroidism, followed by hypothyroidism, and then recovery. In Riedl's thyroiditis, there's a hard fixed thyroid gland, a rock hard consistency. It has compressive symptoms like difficulty in swallowing, breathing difficulties, and hoarseness. Symptoms of hypothyroidism in advanced cases. In neoplastic thyroid nodules, the most common presenting symptom is a thyroid swelling. Enlarged cervical lymph nodes may be presentation of papillary carcinoma. The recurrent laryngeal nerve paralysis is also very suggestive of a locally advanced disease. The second presenter. I'm not sure he's here. So on examination findings, WHO classification.
Which part are you presenting?
So I presented from the introduction to the clinical features. So he's supposed to present from examination findings, investigation, stage.
Wait, Bukola, what is your topic?
Classification and evaluation of goiters.
Classification and evaluation.
Yes, sir.
So you are presenting the classification, he is presenting evaluation. Or how did you divide it?
Yes, sir. That's how we divided it. So this is supposed to be from his parts.
Has he joined us?
Yes, I'm showing that he's here, but
Mr. Bello, are you with us?
Good evening, sir.
What happened? Why are you just joining the presentation now?
The network here has been bad, so I just had to move to a cafe to use the network here is bad.
Okay.
Yes, sir.
So what part are you presenting?
Examination findings.
Even you people have derailed from the presentation. Okay, let me just allow you complete the presentation, then we'll now make our comments. Go ahead.
Okay. Good evening, consultant and other members. I'm starting from examination findings, which is WHO classifications of goiters. Grade 1, you have 1A, which is goiter can be felt but is not visible, even with the neck extended. That's 1A. 1B, goiter can be felt and is visible with the neck extended, but not visible with the neck in a normal position. Grade 2, goiter easily visible with the neck in a normal position. Grade 3, very large goiter. Then the simple non-toxic goiter. On examination, visible swelling. This shows the goiter is always easily visible and moves up and down with swallowing. Size variations. The goiter may range in size from small to giant and can affect one or both lateral lobes, the isthmus, or all lobes. Multinodularity. In about 75% of patients, the goiter is multinodular involving both lobes. When unilateral, it can be either multinodular or unilodular. Simple goiter. Other examination findings. The veins. Superficial veins may be engorged, indicating impeded venous return due to erythrostenal goiter or compression in the superior mediastinum. Consistency. A simple nodular goiter may feel soft and cystic or firm with localized cystic or harder nodules. The edges are definite and the swelling is not attached to the underlying tissues or overlying skin. Cervical lymph nodes, usually not enlarged. Voice changes. Some patients may have a change in voice, but many do not notice it. Toxic goiter. Cardiovascular signs. The pulse is rapid, greater than 90 beats per minute. Arterial fibrillation or extrasystole is irregular heartbeat. Blood pressure. Elevated systolic blood pressure and increased pulse pressure. Congestive cardiac failure. Possible in severe cases. Hand and tongue tremor. The hands warm, moist, and fine tremors when fingers are outstretched. The tongue, fine tremors when protruded. And the reflexes. These reflexes. Reflexes are very quick and responsive. Exostomus, which is protrusion or prominence of the eyeball, usually bilateral, occasionally unilateral. The incidence occur in about 25% of patients with Graves' disease. The timing appears before, during, or after the systemic manifestation of the disease. Non-infiltrative exostomus, mild lid retraction, lid lag, and proptosis. Toxic goiter, infiltrative management, exostomus, severe retroorbital pain, periorbital and conjunctival edema, diminishing visual acuity, papilledema, scotoma, corneal ulceration, conjunctivitis, and lacrimation. Pretibial myxedema, skin infiltration. The pretibial skin and sometimes the dorsum of the feet are infiltrated with a mucin-like substance, leading to irregular thickening and coarse hair. Thyroid acropathy, clubbing of fingers and toes. Thyroid gland enlargement, present in 98% of patients, uniformly enlarged and soft in primary thyrotoxicosis. Firm and multinodular or single nodules in secondary thyrotoxicosis. The vascularity, increased vascularity leading to chill and brew. Significant features. Preference for cold weather due to heat intolerance. Excessive sweating resulting from increased metabolism, increased appetite and weight loss. Despite increased food intake, weight loss occurs due to heightened metabolism. The important sign: hyperkinetic movements, rapid and jerky movements, pulse rate, regular pulse rate greater than 90 per minute or atrial fibrillation, palpable thyroid, enlarged thyroid gland on physical examination. Neoplastic goiter, clinical examination, palpitation of the thyroid. The swelling may present as a single nodule, which can be firm and movable within the thyroid or hard and fixed. The entire gland may be irregularly enlarged or multinodular, hard and craggy, with or without attachment to the trachea and surrounding tissues. Cervical nodes. Cervical lymph nodes may be enlarged, firm and mobile, or hard and fixed. In some cases, cervical nodes may be enlarged without an obvious swelling of the thyroid. Vocal changes. Hoarseness of the voice can occur, and laryngoscopy may reveal abductor paralysis of a vocal cord. Secondary deposits. Secondary deposits in bones may be present and can be warm, soft, and fluctuant, often with a brew. Investigations for simple goiter. X-ray, neck and thoracic inlet, anterior, posterior, and lateral views to show soft tissue swelling and calcification. Displacement and narrowing of the trachea may be visible, particularly with large or retrosternal goiter. Ultrasound scan, useful to distinguish between solid and cystic swellings. Helps determine the actual size of the thyroid, safe for use in children and pregnant women. CT scan, best for assessing tracheal stenosis, especially in elderly patients with large goiters and respiratory tissue issues. MRI, similar uses to CT scan for detailed imaging. Thyroid function test, essential to measure serum thyroid stimulating hormone to exclude subclinical hyperthyroidism or hypothyroidism. Additional measurement of serum T3 and T4 may be done based on cost effectiveness and clinical indications. Laryngoscopy, direct and indirect laryngoscopy to examine the vocal cords, essential for detecting asymptomatic paralysis of the recurrent laryngeal nerve. Investigation for toxic goiter, sleeping pulse rate, observation. In anxiety state, pulse rate is high when awake, but falls below 90 per minute during sleep. In thyrotoxicosis, the rate remains high even during sleep. Charting the pulse during sleep or using a monitor, a rate greater than or equal to 90 is very suggestive of thyrotoxicosis. Achilles tendons reflex duration. The time taken for the Achilles tendon to contract and relax, recorded with a kinemometer, normal duration is 200 to 280 milliseconds. A shortened duration is indicative of thyrotoxicosis. Thyroid function test, T3 and T4 levels, elevated serum TT and T4. Thyroid stimulating hormone levels, low or absent thyroid stimulating hormone levels. Thyrotropin releasing hormone stimulation test, no elevation of TSH after injection of 200 microgram of TRH. Radioactive iodine, uptake, high uptake. Thyrotropin receptor antibodies present in Graves' disease. Laryngoscopy, essential for all patients suspected of thyroid neoplasm to rule out cord paralysis or paresis due to recurrent laryngeal nerve involvement. Laryngeal infiltration, laryngeal pathology such as papilloma of the vocal cord, physiology, X-ray of the neck and thoracic inlet may reveal fine steep calcification suggestive of psammoma bodies in papillary adenocarcinoma. Detection of tracheal displacement and narrowing. Identifying secondary deposits in the lungs and skeleton. CT scan and MRI. Useful for assessing tracheal stenosis and detecting retrosternal extension of the goiter. Thyroid scan. A thyroid swelling may appear cold. Approximately 50% of cold solitary swelling are part of multinodular goiter. The other 50% might be malignant. isotope imaging, pentavalent technetium dimacaptosuccinic acid, or iodine 131 methyl isobenzyl are used to determine the extent of local disease and monitor recurrence. Fine needle aspiration cytology, used for diagnosing papillary, medullary, and anaplastic carcinoma. Small risk of false negative results and difficulty distinguishing between benign and malignant follicular tumors. Serum markers. Serum thyroglobulin elevated in papillary or follicular cancer. Serum calcitonin elevated in medullary thyroid cancer. DNA analysis for mutation of the red gene in suspected MTC in MEN2 syndrome. Additional investigation for MTC. Screening for multiple endocrine neoplasia syndrome. Ruling out pheochromocytoma to avoid a crisis during surgery. The tumor is staged using the TNM classification. Tumor size and extent with the thyroid nodes, presence of regional lymph node metastasis, presence of distant metastasis. T1, which is subclassifying to T1A and T1B. Tumor 1 cm or less in greatest dimension, limited to the thyroid. T1B, tumor more than 1 cm, but no more than 2 cm in greatest dimension, limited to the thyroid. T2, tumor more than 2 cm, but no more than 4 cm in greatest dimension, limited to the thyroid. T3, tumor more than 4 cm in greatest dimension, limited to the thyroid. T4, subclassifying to T4A, T4B. T4A, tumor of any size extending beyond the thyroid capsule into surrounding soft tissue. Examples: subcutaneous soft tissue, larynx, trachea, esophagus, or recurrent laryngeal nerve. T4B, tumor invades prevertebral fascia, encases the carotid artery or mediastinal vessel. All categories may be subdivided into solitary tumor or multifocal tumors. The largest tumor determines this classification. Nodal staging. NO, no regional lymph node metastasis. N1, which is N1A and N1B. N1A, metastasis in ipsilateral, same side, cervical lymph node. N1B, metastasis in bilateral, midline, contralateral cervical, or mediastinal lymph node. Metastasis staging. MO, no distant metastasis. M1, distant metastasis present. Conclusion. In conclusion, understanding goiters involve both the classification of the types of goiter and a thorough evaluation process. By categorizing goiters into diffuse, nodular, and multinodular types, we can better understand the underlying causes, which may range from iodine deficiency to autoimmune disorders. The evaluation of goiter is equally crucial and involves a combination of clinical assessment, imaging techniques, and fine needle aspiration cytology to determine the nature and potential malignancy of the thyroid enlargement. It is essential to recognize that early diagnosis and appropriate management can significantly improve patient outcomes. Through continued research and advancement in medical technology, the future of goiter diagnosis and treatment looks promising. References. Thank you, sir.
Okay, thank you very much for the presentation. It's now time for comments, questions, and contributions. If there's any one with questions, you can please unmute yourself and ask your questions or make your comments. Any questions, please? Yes, I asked you to be reviewing the topics so that you will have relevant comments and questions, contributions as well. So please, if you have any questions, go ahead. I can see Dr. Bima is not with us, the resident. Okay, it appears you don't have any question. Now, the presenters, if you look at your topic, you know your topic is categorized. There is someone who is going to take the management and so. Yours is classification and evaluation. Okay, but you dwell mostly on etiopathogenesis, which made your presentation bulky and it's too lengthy. Initially, the classification the first presenter gave, where she classified goiters into simple goiters, nodular goiters, toxic goiters, neoplastic goiters, inflammatory goiters. Okay, that is a standard and acceptable classification. In now discussion, you now derailed from the classification you initially presented, which you would have just given us just short notes on those classes. If you talk about simple goiters, you define simple goiters and tell us the types. Simple goiters could either be endemic or sporadic. Endemic affecting up to 10% of the population. Talk about sporadic. Talk about some key silent features of them. If you talk on this, in fact, you don't need to come back and start presenting their clinical features because it's going to be repetition. Okay? You go into nodular goiters, you now classify them as either solitary nodules or multinodular. Okay, the way you did that, and your plastic benign malignant, you now talk about, but if you look at your slide after the classification, you did not follow the outline you gave us, the classification. So this will make your presentation cumbersome. And if you are asked to summarize your presentation, you will have difficulties in summarizing your presentation in just 5 minutes because you went into broad classification, even though you did well as an S1 student. These presentations you are seeing, you keep on repeating them. As I told you in the very first presentation, the same conditions you see in general surgery, you keep on repeating them until you finish. So at every stage or every level of your training, there are expectations. Okay, so we are concentrating mainly on the evaluation. Now, when you classify them, you know their classes and how to evaluate the history, examination, and investigation. All those stagings, they are under all those etiopathogenesis. We'll give you a separate presentation for all those ones. But if you bring them into the presentation, it will make it very, very cumbersome. But by and large, you did well. I will not ask you questions for now. Okay, I'll allow our HOD, as if I can see Ahmed Shehu Umar on this presentation. Dr. Ahmed Shehu, are you part of Ahmed Shehu Umar? Okay, maybe it's Dr. Ahmed Shehu, are you with us? Okay. I think he's not. Ahmed Shehu is a general surgeon from Zaria. So I can see his link, his name on the but it seems he's not. Okay, maybe we'll give room for the HOD to make his comments and on the presentation. Thank you. Thank you, everyone.
Thank you, sir.
Yeah.
Thank you very much, Dr. Bashir. I'm really impressed with the consistency of these presentations. How I wish many more of the medical students in this class will also have access to this, because I'm not sure other units are doing it this way. For those of them that are interested, maybe we'll find a way of inviting them also. It may also stimulate them, because as they rotate around within the department in the hospital, they may not be that lucky to get it presented this way. It also signifies some commitment. That's generally. The other thing I noticed, actually, Dr. Bashir had mentioned the defects in this type of presentation, because if you are asked either directly or in theory, you have to study the question and make sure you understand it. Because if you write out of point, that may not necessarily give you extra points. And if you waste your time as students in some other things that are not required, it is very, very unlikely that you will have enough time for what you are supposed to do. So it will not be to your advantage. So the first thing is, make sure you understand the question. For example, evaluation. I hope you all understand the fact that evaluation may be misconstrued. The definition is what Dr. Bashir gave at the end. You want to evaluate that symptoms, that patient, towards arriving at a diagnosis. You've taken the history, you have examined the patients. Definitely you have some auxiliary or specific investigations, result of which you coalesce together, as it were, to arrive at a diagnosis. Because that is what is going to help you. Yes, you observe the fact that when you have the way they present, it will be very easy for you to be able to say this is the thing. For example, if it's simple nodular goiter, how does it present? What is the patient likely? Because I didn't hear any of you saying the patient will present this way. You just as if it's copy and paste. You know, if we want you to write a theory question, we are likely to ask you specifically, you know. especially in terms of evaluation. When you want to evaluate a patient with anterior neck swelling, then you will list your form of investigations, specific investigations, general investigation, to note the effect of that swelling on the body. You know, evaluation, you will go to specific areas. Okay? This fellow will just say, or present with anterior neck swelling. It is your evaluation that will make it simple, nodular or multinodular. Simple in terms of no thyrotoxicosis effect. You understand? As it were, benign or malignant. It is your evaluation that will stand it out for you that this is indeed likely to be malignant or non-malignant. Well, maybe I didn't concentrate very well. I don't know if Dr. Bello mentioned something about distance metastasis. Because the fellow will just tell you anterior neck swelling, this is what I feel. Before you know it, you may have nodules on the scalp. You may have lymph nodes in the neck or supraclavicular area. It is during your evaluation of what the presentation is that you will come out with it. I know this is still S1, but then you must, like I said earlier on, you must understand the question to be able to answer concisely to it or speak to it concisely. But by and large, for you to go in depth into all this, I hope you will still keep it in your knowledge so that when you need it, you will be able to bring it forth. So that is just my observations for now. Thank you very much.
Thank you,
Thank you,
sir.
sir. We are grateful, sir.
Thank you very much, sir, for your wonderful contribution, sir. So I don't know if there is a way the group rep can be extending the link to other members of the class so that they can be joining as the HOD highlighted, because it will benefit them. Is Nikki in the meeting?
Yeah.
Is there a way you can be sharing the link to this particular group only have one presentation left?
Yes.
We have only one presentation. Then we have bedside on Friday.
Yes, I noted that. I think what we can do, you know, of course, by Monday, this group will go to medicine.
Yeah.
I don't know how busy medicine will be. I don't know what activities they will have, such that those that have passed through this place, through surgery, that will be doing medicine, if they are interested, they can also join us. But what we will do, what we should do, probably when the fresh groups comes, we can extend it to the batch leader, apart from the semi-unit.
Okay.
So that, because this is very, very important, and I indeed like it very much, so that they are exposed as much as possible to what we have. I do know that most of the time, they don't go back or come back to the hospital after 5 p.m.
Yes.
So in terms of clerkship, I don't know how far they have gone,
Yes.
but with time.
For our own unit, everybody must present.
Okay.
They have to, all of them clock their patient, and we listen to their presentations and mark it.
Okay, I hope you are doing assessment, because at the end of the rotation, I will want to have the list of their presentations and how well they have done, or how unwell they have done. That one may
the group that
will be
just
able.
finished, I have their clock sheet with me.
Okay.
They submitted their clocking. So these ones, they also all clocked. Before they leave the group, they will submit on Friday so that I can assess.
Okay, please, I will send you the format.
Okay.
Such that after assessment, you'll be able to put their marks down, their grades.
Okay,
Absolute grades, not ABC for now.
okay.
Absolute grade, so that it may be upon how many marks are you marking them? Is it upon 10?
Yes.
Okay. So we'll now be able to prorate it.
Okay. It's okay.
Thank you very much. Then, if possible, if I don't know how you do it, maybe history and what do we call it now? Physical examination.
Yeah.
Have you been have you